instrument delivering through that. So you can put multiple instruments without seeing any scar on the patient body and see it is going and trying to. It is a grasp-up which you can hold comfortably and you can do surgeries in gastrectomy. That's the scarless laparoscopy. This has come with a new technology where like it gets a metal leaf which goes inside the patient body and this holds the gallbladder. Then it detaches there and comes out. Then you put a magnet outside. That magnet pulls this metal and retracts the gallbladder. And then you do the surgery. And so once you complete your surgery, so you pull it out. How to pull it out? Same the metal leaf you have to connect it and just pull it out to the incision. Yeah, the light source, the transmitting antenna, it goes to human body and we just get details of it. The problem in capsule endoscopy is it is not therapeutic. It cannot cauterize, it cannot take a biopsy. So what to do? The spider capsule. Spider capsule can open inside the patient body. It can crawl on intestine. It can cauterize. It can take a tissue. It has been trial on animals and it is successful. Presently, the trial is going on human. Natural orifice surgery. I have told this is like going through the natural orifices, fixing instrument what you saw and doing the surgery. Before, not only this technology and just the instrument. Regarding the patient paper, which are running a hypen, this is a rand machine which looks like a dialysis machine. It runs cisplatin or mitomycin with a very high concentration which you cannot give through the vein or into the systemic circulation. So whatever microscopic cells are there, they die and the results are very good, particularly for appendiceal and ovarian and the primary mesenchymal lesions. We have done 82 cases with no mortality with a good result. This comes to the next. Delivers the drug like an aerosol, so it can reach the crevices, and the difference is it is normal temperature, high pressure, 12 millimeter of mercury pressure with normal temperature, and because it is using aerosol, nobody will be in the operation theatre. You have to fit it, connect it, including the anesthetist. Your dose should be a glass door. So the anesthetist will stand outside. You will look into the monitor. For that 30 minutes or 40 minutes, it has to run and it delivers. We use the CT injector. You must have the radiology people if you are here. The CT injector. You use the CT injector into the patient body. Hold head, fix it with the instrument, and that delivers the drug. Like you see, this is nobody within the operation theatre, and this is delivering. And once you have to put the insufflation and the CT injector goes inside and that delivers the drug. You see the aerosols coming into the patient body. And you can, once you do, the ascites goes because the lining, the carcinoma cells become less active and patient gets a quality of life. It can be repeated. The cost comes around 75 to 1 lakh per session. Anybody has seen this material? And it's trying to show that how small it will be, that is like 1 to 10, 100 nanometer. It will take the cancer affected cells, not only affected cells, it will transmit the findings of the visualization what you are seeing, and if it detects a cancer cell, it will go near the cancer cell, identify it, and then deliver energy, either it is a chemotherapy drug or a radiation like a brachytherapy what you get, and take out the cancer cells. So this is lot of research going on this, and hope one day our next generation will get this. But you have a 3-dimensional CT, 3-dimensional MRI, you superimpose on the patient body, try to localize where to put the incision, how much you have to extract, where is the foreign body. So this is like, once you localize that, your incision will be directed that, and you can reimpose and see whether the direction of the surgery is going well or not. So you reimpose, palpate it, reimpose, put the incision, then use. This is the area of interest where you are feeling it. Then you know this is where I have to cut. That's the pathology area. then you put the incision exactly over it. That's the, you can see the epigastric vessels, you can avoid that, and you put the incision over that and do the surgery. See, exactly over that he is putting a small incision and you can directly push that. Integrating technology with intelligence. This is coming in 2027. That is what committed by Ethicon. So Ethicon with Google is combining together, and the technology is by Bob Surgical. All three coming together with the Surgery 4.0, where we will have a lot of artificial intelligence technology and robotics. The robotics is by Ethicon. The data and artificial intelligence is by the Google, and the Bob Surgical will give other technologies into it, and they come with a very different robotic system in 2027. Telesurgery, it happened long ago. Then it is like moon landing never took off, but again it is revisiting. It's 2019. It is like they started animal experiment in China. Now China, it is a routine procedure of telesurgery. Like this is operating on a liver on an animal, and is staying like 50 kilometers away from it, and using a high-speed internet. The surgeon is operating through a robot fitted to the patient and getting operated safely. And all the robotics, all companies now trying to get this technology to do telesurgery. Telesurgery became revisiting happened because of expansion of robotic surgery across the world. Can robots replace surgeons in future? This movie nobody forgets, starting from poem like endoscopic surgery. And this is an example of gallbladder surgery when you are doing. So when you operate, an expert operates, it takes the gun and sees how the expert is operating, and he learns the anatomy also, what has been fitted to you. And that thing will tell you artificially where to operate, which area not to do. So it helps. Once you see that, you know which area you have to avoid. The green area is the area where you should operate, the red area you should avoid. So what happens, this is given an example, like is a surgeon which is supposed to operate in that visualized area where it is directing the surgeon, but he went out of it and tried to resect and kept dissecting away from it, and suddenly he saw the bile coming through that. Because he had at the junction of cystic tendonitis has biliary injury, and that is because we are just an example of using artificial intelligence in modern surgery. This is how we all dream approach and outcome. Robotic surgery will most likely lead to the full applicability of minimally invasive surgery benefits to the most complex procedures, and it reduces the learning curve what we get with the rigid instrument and in laparoscopy. Innovation and changes are inevitable and need to be adopted in the field of surgery. We should not resist it because it is kind to in place. Even the government institute, central government institute across India, all Indian institutes, JIPMER and regional central institutes where you are getting, everybody has got approval for robot, and many of them have bought it and doing it routinely. The number of robotic GI surgeries what is happening in JIPMER is more than what we are doing in India. So it is nothing to do with private and government. Technology-driven surgery ultimately should be patient-oriented and cost-effective. This is my sentence. It should not, just because you have a technology and instrument, don't apply it to every surgery and every bit of it. It should be patient-oriented and cost-effective. Then only you should adopt it and use it. Thank you.